My name is Dr. Deanna Dwenger.
Say that one more time, the recording came on, yeah.
My dog is barking because I banged the table by accident. So my name is Dr. Deanna Dwenger. I am the Executive Director of Behavioral Health for the Indiana Department of Correction. I'm a psychologist by training. I started my career in the actual field teaching or working at Newcastle Psychiatric, which is our most acute care facility. So it's 128 bed. It's run much like a state hospital, and then have promoted into leadership. I've been at DOC for about 2.5 years now, came over from the vendor side. So when I was at Newcastle Psychiatric, it was common, yet I'll say uncommon, for us to release someone from Newcastle Psychiatric to the state hospital. A lot of times it was Logansport. They went to Isaac Ray. Now it's a little bit more diversified based on the need and what the patient is coming out with. But we had gotten pretty good at inpatient commitments and had a pretty streamlined process. The problem was this gap of patients who were on involuntary treatment and involuntary medication at Newcastle Psychiatric or one of our mental health units in the state of Indiana, where we had the ability to make sure that they were taking their meds and that they were going to group treatment. We had a little bit of control over kind of their day-to-day activities. The problem is that they're very, well, problem and good thing, I guess. See, this blessing on Thursday is really a stretch, but it is really helpful because we're able to stabilize them when they're with us. But we also know that when they leave us, they're unlikely to either continue their meds or to show up to their appointments the way that they're showing up to them now. So we had this gap where we knew that they were well enough that they didn't need inpatient hospitalization and wouldn't have maybe fit criteria for inpatient hospitalization, but also didn't want to release them to the community kind of on their own accord and hope that they showed up to appointments. Even though, and I'll talk much more about this on Thursday, we have what's called a transitional health team, and they're trying to make connections for that patient in the community so that they're getting their meds, they're going to their mental health appointments. That also includes medical services. So, you know, if they're on dialysis or they've got diabetes and they whatever blood pressure meds they might need, transitional health is helping them into the community. But as many of you probably know on this call, it's really hard for you all to have an appointment with Johnny, who's leaving incarceration today, but Johnny doesn't show up. And so you have lots of holes in your books because their no-show rate is unfortunately really high. So anyway, we have kind of identified this population that is stable with us and that we feel really confident that if they stayed on their medication and they stayed connected to a treatment provider, that they would be stable and they wouldn't return to us and they wouldn't decompensate to the point of needing state hospitalization. So that's the group we're targeting right now. We have done 4 outpatient commitments. We just kind of tore off the Band-Aid. Actually, we had a perfect candidate who needed it coming from Newcastle Psychiatric, was completely stable. He was very cooperative with his treatment at the DOC. And so we thought if we had a judge tell him that he needed to continue with that treatment, he would also be really successful in the community. And of those 4, none of them have returned to us. I'll be excited to hear from all of you, maybe who we have worked with. It's been Bowen, Gallahue, and what's the one in South Bend? Oaklawn. That we have released our folks to. And so far it's going well, but unlike inpatient commitment, the big thing is when it's inpatient commitment, we always go to court with the gatekeeper being that community mental health center in the county of the prison. So we've only really worked with those 4 counties where our inpatient mental health units are historically, versus outpatient commitment is going to be based on where that incarcerated individual is releasing to, which we don't have control over and you don't have control over because they're going to return to the county that they were convicted in. So instead of just really working closely with 4 community mental health centers, now we'll be working with all of you. So just kind of want to give you a heads up what this looks like. It's still, I mean, we're still figuring it out. So Thursday, hopefully will be a good conversation about what's worked, what we've kind of ironed out in the 4 we've done, but it's also very open. And I want to work collaboratively. I just want to use the state resources to the best of our ability. You know, we want to make sure that people aren't returning to us and we're having a justice response to a mental health need, because historically we've done a lot of that and that doesn't feel good for any of us. So that's what we're going to talk about on Thursday. That's kind of a preview.
Wonderful. So before we go on to other updates and other services that CMHCs can partner on, are there any questions regarding that anybody would like to ask? And if we don't necessarily have the answers today, again, we can, have a conversation regarding this on Thursday too. Any questions? Did everyone receive the process that Denise emailed out from Dr. Dwenger? Okay, wonderful. So, and if you, have any feedback on that, any thoughts around that, definitely pay those forward. I do want to really recognize DOC and Dr. Dwenger. It really has been from the beginning. We need to start doing this. How do we make this work? How do we make this work for your members? How do we make this work for those we serve and DOC? And so it's been very, very much a great discussion. I also want to recognize Clayton, who's on the phone, on the line, with being the first one. They really were helpful in that process and trying to figure out where those kinks are and what that looks like. So any other questions regarding that? Okay, well then I wanted you to kind of highlight, Dr. Dwenger, some of the other initiatives you're doing around transition and services. And I know DOC has done quite a bit to improve the behavioral health access. And so anything else that our CMHCs can partner with you on for those that you serve that we might need to know about?
If in your county, you are not aware of who your transitional health liaison is, please bring that to my attention on Thursday. We have 21 transitional health facilitators that are inside our facilities trying to make those connections for the patient. So Johnny's getting out next month and he needs blood pressure meds. He needs a follow-up from a surgery he had last month and he needs behavioral health care. The facilitators are really facilitating that prior to their release. The liaisons, we have 10 of those and they are in every parole district and they are as needs come up after the fact. So maybe Johnny releases and he doesn't have any needs, but the transition to the community and going to the grocery store and some of those things we take for granted that are really, really difficult for them to kind of adapt to and get back into normal kind of everyday living, those liaisons will pick those up and then make sure that those services are happening. So if Johnny is not have anything set up before, gets out and needs something, the liaison would be a great person to have a good connection with or a relationship with so that they can do easy handoffs and make sure continuity of care and that you're getting information about why that person might be being referred to you, or the parole agent, may have a lot of information to give you too about what they're struggling with. They really get to know their patients. Parole has changed a lot over the last couple of years. I will just say, if you're not familiar with parole and what they're doing, it used to really be that the incarcerated population was afraid to be on paper, is what they say, and to have parole time because they felt like the parole agent was constantly just trying to catch them in something and then they would return them to prison as a parole violator. Over the last 2 to 5 years, that's changed a lot into, we actually want you to stay in the community, but if you're struggling, we want to connect you to someone. They're almost functioning more as social workers these days and really making all of those connections to the community mental health center. So I would say that's one thing. If you don't know who your liaison is or who your parole director is, I can give you some of that information on Thursday. Another initiative is when I came on board 2.5 years ago, the reason they made this position a psychologist, it had never been an actual mental health person before, was because they were going to add mental health staff wellness initiatives. So I also oversee the director of staff wellness, and we do a lot more with staff initiatives. So I've probably reached out to a good handful or two of you at this point now when we've had an officer or a sergeant or a lieutenant, someone in the facilities who has been struggling. We've had people who are new to corrections and be triggered in training when we're doing like suicide prevention trainings or something. I think we've referred a couple of people while they were in NEO training. So definitely that's a new initiative. If you haven't worked with me, maybe you've worked with my director. Her name is Peyton Sutton. So that would be another person if you're interested or you need more clients and you're close to a prison. By all means, I've got people for you. A lot of times I know they're really looking for care, and we have pockets where we're just really struggling with getting quick appointments for our staff. So that might be another thing if anybody on your team is interested in working with staff.
Yeah, that's wonderful to hear that you guys are doing a program around that to help with your staff. And so thank you so much for hearing that. Any questions from the members or discussion items that you guys would like to share?
Hey, Dr. Dwenger, this is Clayton Sparks. We've had a couple, and I think they were pretty successful. They're in treatment now, doing wonderful. I think a little scare we had, which may be an issue going forward, and I don't know the answer of this, was we have to accept the commitment before they leave, understandably. But once they leave DOC has very little control. So we had an issue and we were able to solve it. But I see this being a big problem where they just the last day where they were moving to was out of our area. And so here we are, we accepted the commitment and now we have someone out of our area. We were able to do last minute shuffling with the family and get that taken care of. But so I don't know the answer of that. I know things can happen and it's unpredictable, but having a commitment on someone that maybe we don't have any physical location in that county or that area can be an issue.
Yeah, it definitely helps if they are on probation or parole, because then you've got kind of some teeth in it. If they don't show up to their appointment, you can call the parole officer or the probation officer and they can do some of that legwork. I know some of the concern I've heard from you all has been that maybe your local law enforcement is not going to enforce it, or you don't feel like you've got their support. So it definitely helps if they've got parole or probation. Clayton, I would assume this person probably came off paper and then was wanting to move, and that was kind of part of that. And then we also have lost the ability of having these external folks also saying you need to go to your appointment or let me drive you to that appointment. So I can definitely see that is a problem.
But luckily this person was in treatment with us prior to DOC, which the other, many of these cases, we'll have no idea who they are, which, is a bit of a barrier. They just come to us. Unlike state hospital process where we with a gatekeeper, we put them in there. We usually have a long history with this person. I know our first person, we had no clue who it was, no history outside, of course you guys provided us with it. So having that and then somewhere else, and of course then parole, and that's foreign to a lot of us, in this kind of setting. So on Thursday, will you bring a list of the liaisons and
Sure.
transition persons of where they're at? Because I know we're in multiple counties, and so it's going to be different. And in some counties, we deal with it more than others.
Yeah, I'll bring a list of liaisons and the parole, kind of who's over parole.
Yeah.
Because you definitely do have support in them. The problem is only if they're not quote unquote on paper anymore.
Okay.
And
Yeah,
I'll talk
that would be
Thursday
great.
too, I'm sorry.
Yeah, I think that would be a great resource, Doc. The other thing that I wanted to share with all of you, I've shared our provider map with DOC to help with that connection of the counties and make that connection. And if they come up against not knowing who to reach out to, Deanna and I communicate about who might be that best person. So try to help in connecting those dots for DOC and for all of you. So I think making that connection with having those resources, but those probably change, right, Doc? Would you say, like the parole, do you have turnover in those roles, or does that, no, it stays pretty consistent? Okay, great.
Parole is pretty steadfast. Honestly, they knock on wood, they barely ever have vacancies and there is not a lot of turnover there.
Great. I want to know what their secret is.
Yeah,
That's
Troy
awesome.
Keith, that's the secret. That
Okay.
man is wonderful. And I'll say, I do think, Clayton, about the, like, if you have prior history with them, so far it's been 50-50, because half the time they're returning to their home community where they are well known. The other 50%, though, I have a feeling are going to be people who committed a crime in a different county. And then, they may have been getting services in South Bend, but they committed their offense when they were in Indianapolis. So now they're returning to Indianapolis and going to Gallahue, but the records are all somewhere else. And we are happy to share all the records from DOC, of course, as much or as little as you want. And I will reiterate on Thursday, though, that this commitment has nothing to do with what we've been doing, right? Like, you all will do what you think is clinically appropriate for that patient. You don't have to follow our treatment plan. You don't have to do anything that we've been doing, but we are more than happy to share those records. That's not the same as really knowing the person. I totally understand that. But yeah, I think it'll be interesting to see what the percentages of people who are returning to mental health networks that are very aware of them versus not.
And the process went relatively smooth. I think we were talking different languages once we kind of had a common language. It did much better, but I think we were the first ones, and that was just kind of throwing everything out and seeing, oh, okay, that doesn't work.
Well, and unfortunately for you, as Zoe said, we had been planning this for probably 2 years. We had to make sure legislation was going to support us. We were looking at, legally, what do we need to do? And I was talking to Zoe and really trying to get everything in line. And then it was all of a sudden, this man is releasing in 3 weeks. He's the perfect candidate. He's been with us and gone in and out 5 times. And it was like, at some point we have to just tear off the Band-Aid. And you guys did not have the amount of time that we would have liked. So I really appreciate all that you did to jump in there, but we didn't want to miss an opportunity for that patient.
No, I think it's going well so far with the 2 we have. So I don't know if that's a great measurement yet, but
yeah, hey, that is a great measurement, and we need to share our success and what we're doing with that relationship with DOC. I am all about having that positive narrative. And so that is a positive narrative story that we need to share with our local counties, commissioners, with our legislators, and the work that we're doing. So thank you to community and Clayton for doing that, and for DOC and working through that. And for the others, Bowen and Oaklawn, also those went very smooth as well. So we are meeting the needs in our communities and we're showing up. And so let's share that good news story. So any other questions for Doc before we move on to just general updates? You guys are a quiet bunch. Hopefully you'll be noisier on Thursday because we have a lot of fun planned. So speaking of that, if you are not registered, you can still get registered. We will be in Bloomington tomorrow with committee meetings. If you want to join us for that face-to-face interaction, those committee meetings don't have like a lot of formal agenda. It's really for people to connect and network with each other because they miss that connection. And so if there is any business items like in the mobile CCBHC, Andy will be sitting in on that, and we can at least share some minutes that have come up. I know that that's been a concern about people missing out if they can't be there in person. So we're trying to balance the in-person and the not. And so wanted to share that with you. Also wanted to share, we do have a pretty important board business meeting on Friday. It is our meeting where we're voting for the board of directors for the Indiana Council, as well as voting for updated bylaw changes regarding our board members and the length of time that they can serve. And so if you are a CEO on this line and you are not going to be there on Friday, please make sure to send Denise a proxy so that we can ensure your voice is heard. And then we will really be spending some time not only talking about our policy platform and strategy, but also around the whole CCBHC RFS. I've met with David Josie. I have some, we have been talking about some things that we can do in regard to our system around CCBHC. And so he is also going to be part of that discussion. And so just an important discussion on Friday regarding our system. And then just a few other updates. I do want to welcome Hannah. You guys will all be able to meet her in person. She is our new data warehouse project manager. And yesterday it went out. We are starting demos for vendors for the statewide data warehouse, which is very exciting that we are in that next step on that journey. And Hannah will be leading that. And so your data analytics team, if you're not plugged into that discussion, please reach out to Demetris at Aspire. It has been our fearless chair, and Andy has been helping with that committee as well. Please make sure you're plugged in. I do also want to share, we have a new member of the Indiana Council. That's our non-CMHC member, and that is Clubhouse of Indiana. And they will be with us on Thursday to connect and learn with all of you. We have a number of new CEOs. I see Jennifer from Family Health Center. She's not new necessarily to the clinic, but she is new to CMHC. And so we're just going to be introducing those new CEOs and changes there. The group home capital, Andy has contracts out and they are being signed. So that is exciting to be able to get those funds to all of you. As well as at the conference, we'll be reviewing the great work that our Racial Equity and Leadership Committee has been doing with the class assessment. You'll hear an update on the CCBHC readiness assessment. And just a few other reminders outside of that. National Council Hill Day at Home is October 18th. And if you haven't heard, there was a federal bill introduced on CCBHC. So it's Senate 2993, and it's a bill to amend the Social Security Act and the Public Health Service Act to permanently authorize certified community behavioral health clinics. So to have a permanent definition. So this is a huge bill legislatively. And on October 18th, we'll learn more about that. And then October 24th, there are a couple of us on this call that will be going to DC to meet in person as a follow-up to that. So I want to thank everybody there. Any questions on those updates before we start to wrap up? Okay, well, just a reminder, if you know of any potential new members that you think would be a good partner, such as Mental Health America, I see Steve on the phone there, and then also Clubhouse, please reach out to Leanne for our membership. And then, you know, just a quick reminder and just looking ahead, if you don't know, we're going to be in a pretty large governor's race. And so your PAC donation to the Friends of the Indiana Council is really important for us as we're moving forward in this governor race. And so that information is on our website. And so just wanted to note that. And then last but not least, I wanted to thank Dr. Deanna Dwenger for being on with us and sharing this information. Looking forward to seeing you in person. And we have a Starbucks winner. Where did she go? There she is. Miss Connie Kerrigan from Park Center will be our Starbucks winner. So let's raise our cups. Looking forward to seeing all of you tomorrow and Thursday and Friday. And so if there's anything you need in the meantime, please don't hesitate to reach out. Cheers to all of you and to a great cup of joe. Thank you, Doc, for being on. See you Thursday. Take care.